Welcome to So You Think You Can Doc, where we get into real stories, real struggles, real doctors, helping future physicians navigate medical school and beyond.
Did I ever tell you about that patient of mine from Germany?
No.
Oh my God. He was a hydrocele patient. And he was a spermatocele patient. And then I did a hydrocelectomy on him. I did a spermatocelectomy on him. And then he had a recurrent hydrocele afterwards. Basically, he had a bunch of fluid around his testicle. And normally you'd like to do another surgery on that to fix it definitively, or you could put a needle in it and suck it out, and it's a temporary fix. And he was like, well, we can do that now. I was like, what? He goes, yeah, just do it. I was like, okay. So I got a needle, put it in, sucked it out, drained it. He goes, oh, okay. Well, I'm going to go to Germany and we can schedule the surgery afterwards. Cause I was like, dude, I think you're going to need surgery. Like it's going to come back if you do this. Didn't tell me anything. Next time he comes in, he's like, I'd like to cancel the surgery. I was like, why? Turns out he went to Germany, got needles like the one that he saw. He saw me use the needle, got needles like that in a syringe and just drained it 5 times. And he said, it hasn't come back since. So I was like, what? So what is it about this guy that he could, and I asked him for permission to tell that story. What is it about this guy that he, without me telling him to do something, took ownership of the project and took it across the finish line without me doing anything?
Yeah. And
Right?
I guess some of it is cultural, right? So, if you're here in the United States and this culture is, okay, if I were to do that, then people are going to look at me like I'm crazy and, oh, what are you doing? And now that's going to void my insurance paying or covering for things, who knows, like all kinds of weird stuff where even when it comes to like my world, it's like, oh, to do dialysis, and our patients in the US feel like, well, if I don't do that, I'm going to die. So this is what I have to do and this is what I should do. While European people are like, well, yeah, I've lived a good life. Like, and they just, you don't have that same very sickly older population that would have continued with this. And I feel like there's this feeling of, well, it's my body. I can make these, choices and no one's going to look at me like I'm, some weirdo. Well, the fact that we're telling the story is a sign that we think it's like, right?
Yeah, right.
Or else we're not telling it, right?
It's not the norm for us.
Right. If it was like, I don't know, your toenail and you saw the, the podiatrist clip it some way, you'd probably go do it yourself, right?
Yeah.
Right? I mean, there's a threshold of, where we draw the line. Obviously,
Like what makes it okay, what makes it not okay.
Right.
And I think the fact that, I think it's one of the defining characteristics of my specialty is that just by anatomy alone, everybody's like, nope, you got it.
Yeah,
right.
No, and that's what I was going to say. You go for a toenail up to a haircut. You go anywhere in the middle.
And the more middle you get,
and suddenly it's like, do not touch.
Wait a minute,
There's a warning sign.
Because
right?
like stuff here or there.
No, but you would say, oh, okay, well, yeah, all the brain is up there. That's important. And when you think of what people are willing to like stick in their nose or their ear, they're not scared of that, right? You always hear about these like pimples that get infected and go into your brain, you die. It's like, nobody's afraid of any of that.
It's crazy because now we're going down tangents and we'll eventually come back down to the source of talking about what our big project is. But it's just part of the reason why I like doing this is because it helps me broaden out and flesh out all the connections between these very disparate events and things that are hard to connect sometimes.
Well, and in essence, this is where this kind of started, right? Yeah. It was like me and you sitting down and just like talking about stuff. Right?
Yeah.
And it was just like, wow, I wish people could hear some of this because maybe they'd get something useful out of it.
I mean, there are always little gems, right? And that's the thing is like, and I think even podcasts now, the best podcasts, I feel like they have oceans of discussion and then little gems that when you really want to listen to the ocean, like that one line can flesh out the whole discussion. Without it, you're just like, wait, what? But that's the art of a good story. Every story has a punchline and then there's a big lead up to it and then boom, and then it all crystallizes.
That's right. Yeah. The context can really add to it. And sometimes you're just not up for that, and you just you get your gem and you feel like you've got it. It may or may not be on point with what they were trying to say,
but everybody from good conversation about tough topics.
That's absolutely where it's really started and fortunately continued. Hi, this is our first episode of So You Think You Can Doc. My name is Allan. I'm a nephrologist in a large academic medical center in a state that has basically two cities, Wisconsin. So we pull from a large area. This is my co-host.
I'm Allan. I'm one of the urologists. And yeah, I'm glad to be here. And
Good.
My name is Emma Sheets, and I'm the everything producer. I edit, I produce, I keep these two on track, and just glad to be here with them.
Yeah, so we've been having a lot of fun. We've been interviewing people who are at all different levels of their career and different specialties and trying to figure out basically what their lives are like. How did they get to where they are and what's fun, what's not fun? We really have this overarching goal of trying to reach people who aren't able to get this kind of information. And the kind of information I'm talking about is what is it like to be in that life? How hard were or what were their struggles getting to where they are now? And maybe letting some people feel inspired or not feel discouraged by the barriers that they're afraid of or that they perceive, which may or may not be real. I think really hearing from people who've gone through it is going to be really important for all of you.
And so we're thinking mostly like medical students who are not sure what specialty to choose, undergraduate students not sure which degree to choose, people in other specialties wanting to build relationships with other specialties, trying to connect all systems of a healthcare system, and then understanding scope of practice. I think that's another one of those things for the reason why I brought the scope, because it was a big meditation on this morning. I just had this idea. It's like, what's your scope of practice?
Mm-hmm.
And I think that's one of the things I think in everybody that we've interviewed, talking to them about, like, so what do you do on a day-to-day basis in your practice has been a wonderful touch point for meditation and understanding other people's day-to-day and, yeah, getting a big picture view of the whole hospital working, getting to see all of the interlinks in the network is really good.
Yeah, some of the things I feel like really get lost is this whole scope of practice, meaning what do people really do in their actual jobs beyond what you're exposed to? So people come in, they say, okay, I'm going to volunteer in a hospital, or I'm going to follow this kind of physician or that physician and see what they do. And generally, what that means, even at the level of medical school, is you do a rotation. And a rotation means you follow that person generally when they're in the hospital seeing patients who are admitted. Like in my job, that's maybe 25% of my job at the most, where I'm actually doing that. Most of my job's actually outpatient in clinics or dialysis units, which is a very different situation from what I do then. So this minority part of my job is kind of seen as what I do every day, and it's absolutely not. And I think people will get misled by this all the time, even at the level of residency or even medical school. So I can't imagine people who are in undergrad thinking about medical school would have any clue what it's like to be in my position, no matter what they tried to look up online. So hopefully we can open up some of those closed doors and show people what's behind them.
Yeah. And I think it's important that we also talked about safe places to have those kinds of conversations, because sometimes people have questions they don't even know they want to ask. Right.
Yeah.
And then being exposed to that kind of conversation and a good conversation, not like, and I think that's the other thing about having it in this kind of a setting that Emma facilitates, because she gets us the room and gets us a nice space, and then we can have all the equipment and we can really just focus on the conversation at hand, so that it can be good conversation about these topics. So we're trying to solve problems and trying to help people and trying to understand each other, because that's really where it started. You and I had these kinds of talks in the lounge, and I always felt better after the talks.
Yeah, and sometimes the talks are the therapeutic part of things, right? Without any conclusion. One of the things we're also looking to get is a lot of feedback for what we should include in the future and who we should talk to, whether people who should be younger, older, different specialties, male, female, different race, you name it. Those things are all available to us because we happen to be in a place where we can really get a hold of those people. We'll also really try to get a mixture of some of the private practice aspects of this, which will be a little tougher for us because we are in an academic facility. But a lot of people have been in private practice before they came here, or they thought about it and made this decision. And why did they make this decision? So I think that can all be useful information for people thinking about what they're going to do with their lives. Emma's been editing quite a few of our videos already. Any lessons from Emma?
Well, I almost ate a spring cheese with a microphone on. So I think I'm still also learning lessons.
I stole a microphone once.
Yeah, that's right.
Yeah, we're
You
still
took
gonna
one
I
use
just
the
home.
walked off with a clip.
microphone.
Yeah.
I was in my car driving. I was like, I wonder how much it got.
What's the range on
On this thing?
Their babies crying.
Oh, boy.
Like, where did that come from? But yeah, we have a couple of episodes without the microphones, and the audio is not great. So if that's really something that's a barrier for you, feel free to skip forward, and there's other episodes after that. So we're learning, right? We're learning how to use our microphones. We're thinking about getting some extra cameras going. Ultimately, that kind of stuff, as well as working on our content. And we're hoping that you'll be able to comment or communicate with us and help us figure out what's going to work best for this. This is a lot of fun for us, so it's pretty easy to move forward. I feel like Emma does the brunt of the tough work, so we appreciate that.
You're welcome.
Right. And hopefully,
Yeah.
medical students and residents will be listening to this while they're eating lunch or something between patients. And one of those gems will hit them and be like, oh my God, somebody is having
Yeah.
a similar problem to me, and spark them to that solution. Because it's one of those crazy things about the way that once you start getting into the hospital setting and in the hospital system, you start getting into the realities of the trenches of patient care, how deep that rabbit hole can get. And sometimes you just need somebody else to give you the right idea, and it helps you keep going. So
Yeah. And like you said, even just talking about it out loud is sometimes enough to get you to think through it, or at least have somebody agree that there's no quick answer to this. Sometimes that's enough. Part of why I'm gonna act like we chose it to be this way, but I don't know that it was really chosen. That Ali's a surgeon and I'm not a surgeon, so I don't do things where I have OR time and the scheduling and the stresses of that. I do minor procedures like kidney biopsies and dialysis catheters, that kind of stuff. But when we have guests that are surgeons, I feel like it's harder for me to relate. Yeah, I saw you brought a special gift here. Or
yeah,
tool?
no.
I'm also afraid to
No.
touch the tools you bring.
Well, this came sterile out of a tray.
Okay.
We just get to hold it. This is it's a laser scope. So it's a laser nucleation scope. So I always joked with my brother. One of the things about like my job that I really do love is like sometimes it feels like get to be a Jedi in Star Wars, because a little laser comes through. But a laser comes through, little laser fiber goes through, and then this is actually a lens. It's a telescope. So if you want to look through it, you can look through it. But it's got a weight to it. It's got a feel to it.
Oh yeah.
But when I think about like what I do on a day-to-day basis when I'm operating, like this becomes like such a natural hold for me. This is what I do a lot of. And we're just going to use it for an experiment. Like when I started out wanting to be a urologist, I never even imagined, right? I didn't even have I didn't have the verbal, I didn't have the words, I didn't have the mental images of any kind of imagine of what this would look like and what this is. And now I know this thing inside out. When I use it, it feels like a natural part of my hand, right? As a tool. And as I sit and meditate on it more and more, it becomes clear, like, how did I end up here? What are we doing here? And really, it's a microscope, right? And my dad is a pathologist. He's a doctor, just not the same kind of doctor as me. And I guess one of those things is the people around me that were telling me to become a doctor, they didn't know what I was going to be doing. They still don't know what I'm doing, right? Because they wouldn't understand, and they're all back home in Tampa, right? But that's one of the things about having that support network and people that can help you understand and see what this is supposed to accomplish. But it's basically an action microscope, right? Because my dad, he wanted me to be a pathologist, right? Every dad wants his son to follow in his footsteps. I didn't want to be a pathologist, but I still respected what he did. Mm-hmm. And now I've found a way to use his tool, because he would always invite me to sit on his microscope and come look at the slide. And I'd be like, oh my God. And he'd sit there and I'd be so tired, studying and things like that. But I would actually learn a lot, especially when I was in medical school. It was very helpful because you're still learning a lot of histology and things like that. Mm-hmm. And we didn't have a discrete histology course. Did you have when you did medical school, how were they teaching it?
I mean, I don't know if it was by itself.
Yeah.
Yeah, I feel like it was. Or at least it was part of many things.
Didn't they turn it into like a system?
Yeah, you do okay, yeah, because it was like you do of each.
But like for us, it
system.
was like the second block was neuro, right? And boy, that was a struggle. To this day, I have a hard time like concretizing in my mind the idea of what all these nerves are supposed to do. So they sort of just throw you off the deep end. And then now I'm learning all of this stuff. And I'm like, I'm sorry, what? I can't even my brain isn't even, I need something to hold to make this real. But nobody ever really, and what are the disease processes we're doing? What are the solutions? We're just looking at problems and strokes and things like that. I had a hard time with it. And that alone was enough to make it a big struggle. But we started making all of our classes systems based. So it's not like, oh, histology, you got an A, anatomy, You gotta be. It
Right.
was the neural block.
system. Yeah.
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 Right?
And that's a tough way to start, right? Because that's like the one you could least put a finger on, right?
Yeah.
Because everything is, yeah, imagine there's nerves that go from here, this side to that side. It's like, yeah, that's really tough stuff.
Yeah.
Where, yeah, if you're looking at, I don't know, just muscles and skeleton, like, so, you know, things that you can see, touch, dissect, see, it's a lot easier. Or even, you know, like urology, at least it's physical structures, you know, whether they're smaller or bigger, just physical structures you can see, follow the path.
Did you have a cadaver lab in your medical school?
Yeah.
Yeah.
I was the first one to back up.
You know what's crazy?
Probably a
I was
sign.
the first one to go in.
Yeah, that's why you're a surgeon and I'm not. No, I remember it was yeah, everybody's like, ooh, and I'm like moving
Yeah.
backwards.
Yeah.
I think I was, yeah, I had at that point, oh yeah, I had passed out at least once. And by the
In the
time I
cadaver
was
lab.
done, no, I passed out in the OR, but that's a different story. But I knew I had the ability to pass out, is what I'm getting at. And I would start getting nauseous, like that would be my thing. And, you know, I joke around with my patients, I say, I'm afraid of blood. So watch out, you know, unless it's in a tube and dialysis machine, I'm fine with it. What it really comes down to, and I used to work on an ambulance, this is bad, but if I'm involved, I'm fine. If I'm an observer, watch out. Then I get in my head and I start thinking, because, you know, if you're involved, it's not a choice, right? When I passed out in the OR, I wasn't doing anything. I was observing, right?
Yeah.
And that's probably a large part of what it was. The first time I passed out, it was a car accident that I just, when I got out of the car and I was looking, but I wasn't doing anything.
Wait, you were in a car accident?
No.
So there was an accident.
yeah.
You came out as a good Samaritan.
Right. But there was already like people there or whatever. So I wasn't actually doing anything. So now I was an observer.
Were you a doctor at the time?
No.
Like, how old were you?
Maybe I was in medical school or something
Medical
like
school?
that.
Yeah.
No, it was
Early
before that.
medical
It was
school or
younger.
late
It
medical
was
school?
younger. I was probably like undergrad-ish or maybe high school age. And
But you came and you observed the scene.
yeah.
Yeah.
Which was a mistake. So I ended up holding onto a fence with my finger grips as I was passing out.
Oh boy.
That was, then I was like, oh, maybe this is not for me, right? But that, you know, that definitely wasn't the first time I passed out, because there was another time. I remember I had I don't know, I used to play a lot of sports and I'd done something to my thumb and it was swollen. Okay, but like 4 months later, it's still like swollen, this, that, and the other. And my mother is an emergency nurse. We lived across the street from the hospital in Brooklyn, New York, like right across, like you can hear every ambulance across the street. And she just took me over and she's like, hey, there's one of my friends, you know, here to look at it. She was the triage nurse for the emergency department, so she could really basically walk in with you. And at that point, I had been introduced to everyone 30 times already, because, you know, mothers bring their kids to meet their coworkers all the time. Anyway, so this guy is looking at my thumb and there's like, oh, there's a dark spot. And oh, let me drain that. And he like, okay, I'm just going to put a needle in. And there's some kid next to me who's getting like his nail cut off, or I don't know what. I was out cold. They're trying to drain my thumb. So again, that should have been sign number 1. Anyway, you know, so what I was getting at is sometimes, you know, you
know that you were the kind of person that when the cadaver lab came, you were like on the outer, like, I don't think I want to be in that. But now you can turn it on.
Well, all
Right?
right. So about 2 weeks in, I'm falling behind, and you know, everybody's in there and they're learning their anatomy and they're dissecting. I'm starting to like, yeah, I'm falling behind here. Yeah, something turned on. I was eating, cutting, you know, because, you know, you get this, I've got loans, I gotta get through this. All right, this is not a choice. You know,
Yeah.
I already knew how much each class costs because I had broken it down, you know, in my head. And it's like, all right, yeah, there's no choice here. I got to do this, right? And, you know, you power through it. Yeah, when I'm doing a procedure, if it's not going, there's a lot of blood, this, anyway, which previously would have just like floored me, I'm fine. If I'm involved, my hands are in there. Standing outside watching, I'm just going to walk away. I'm not going to observe too long to find out what happens next. But yeah, I think some people are just drawn in, right? Like the way you moved forward, I moved backwards, right?
Yeah.
I mean, I had my other warnings, but I don't think that was the whole story. This is different,
Yeah.
right? It's, you know, there's no blood. It's
Yeah.
like, it's a cadaver, right?
But it's also got to be context, right? Because one of the other things about the going in, I remember when I was an intern in Houston, I was in the emergency room and I was doing an ER rotation. We still did a 1 month of ER, and a trauma code comes through, and the ER resident happens to be somebody who I'd rotated with my first month. ICU. And she's back home in her turf. She's an ER doc. She was rotating through the ICU with me. And so we were both off-service ICU residents. And so she's like, okay, you ready? You're going to catch this code? And I look at her and I'm like, what? And then it comes in and then she's like, all right, go ahead. And I was just like, nah, it's not me. It's not me. It's not me. And I'm like, you got to do this. And because I think about it, my brother is an ER doc. He takes that, like that for him, it's religious. He's got it down to a process. And it's like, this is how we handle this chaos. And he can turn it on and then he can turn it off. And so it's one of these very interesting things about what does it take for you to be the one that wants to charge forward? And what does it take for you to be able to go, I think I belong here. And it's not like one is right or one is wrong. It's depending on the time and the circumstance. I'm involved. I have to do it. I'm doing it. Okay. I'm not involved. I'm going to sit back. Right. And it's, those in between states, you know, how do you, especially if you have to transition multiple times in a day, like, you know, operating in the morning, before that there was meetings and I was meeting here and podcasts and I still have to go write some papers kind of thing. How do you transition that kind of thing? So I think that's the thing about, like, when did you notice that, like, oh, when I'm involved, it's okay. Do you remember a first time that happened?
I kind of figured it out really after I was an attending.
Huh.
Yeah, because all through residency, well, okay, I kind of figured out that I was okay with kidney biopsies. If there's a lot of bleeding, you really did something wrong. That I was kind of okay with. And it's ultrasound guided. It doesn't feel real. Look at the screen, you're doing, I don't know. It just doesn't connect with me in that way. So, but the lines, the dialysis lines is where you shouldn't be hitting an artery. But let's say you hit an artery or you hit a vein and, oh, there's like pools of blood. I don't know, something triggers or it doesn't trigger. And there was this thin line where, going from being a fellow to an attending, I was now the supervisor / observer, right?
Yeah.
So, you know, as a fellow, I was in there, right? So I'm like, oh, I'm over this. Like, it doesn't bother me anymore, right? But now I was the observer again, right? And then I started to, so now I start doing weird things, even up to this day, where I don't tell the fellows this. I usually tell them after. I'm like, you know, I pass out, right? I warn them because I think it's really funny to see how they react. But I'll start doing like weird things where I'm helping or doing something, which I'm doing it for me. I'm not doing it for them. Right? I'm like, oh yeah, let me get this ultrasound thing, whatever. I'm like, oh, let me hold this patient's hand under the thing, you know, whatever. Like, I'm just doing like weird stuff, right? I'm like, are you breathing okay? Let me hold this up.
But you're coming at it from a different angle.
Yeah.
And you're actually still very much involved.
Right. And so, well, what becomes more difficult is actually, as these fellows that I'm supervising are better at it, they're in like second years, they really can just do it by themselves. Yeah. And now I need to find something that doesn't look like, because they don't want me helping them, right? So I need to act like I'm not really helping them. I'm helping myself.
Well, I think, but that's one of the hardest things, and I know one of the topics we touched on in terms of teaching is developing that autonomy. The reason they don't want you to help them is because it's like, hey, I can do this by myself, and I need to prove it to myself that I can do it by myself before I go out into the middle of nowhere and Dr. DeGrew isn't down the hall for me to call when something goes wrong, right? But that's such an important step of any physician's education if they do procedures, if it's within their scope of practice. And like, I'm still struggling with that.
Of course, this is the toughest time right now for you, right? Because you were just there, right? Like, and now it's like, oh, I can do that better.
I think one of the things that's very interesting about endourology specifically, and why it's been a little bit easier, is because when you look at the full scope of the urologic surgical education, most of what I do now gets put under the beginners, or like early residency. So learning how to do ureteroscopy, basic endoscopy, tends to be your first 2-3 years. Well, it's not universal and there's no real standard, but it's just what's accepted because it's a shorter case. And then you progress to open surgery, right? And robotic surgery and bigger things. And so most folks don't so most of the residents who I get will have some familiarity. So it's not like I have to teach them big open surgery or something like that and make sure that they know. So they'll have a lot of familiarity with it. So I do feel more comfortable, even if they're a junior resident, being that observer, right? And because I've observed so many, I don't feel like they can do anything really wrong. And so I start trying to do what you're doing, which is going around other parts of the room to make sure, because what always happens in endourology is like something outside of, like you said, that's why there's so much to touch on here. When you're doing a biopsy, it's like on a screen, right? So it feels different. So when we're doing these surgeries now, in order to do this surgery before, they would do this. They had to. And you can't forget where you are when your face is there. But now we have a camera and it goes to a tower and it goes to a screen. So I get to sit and do the surgery like this. And yet, like that, all of this, the stuff that most people are like, what are you doing? It's just, it's there. And then it's like,
Yeah.
like
Yep.
I've got a PlayStation controller.
Yeah, you're dissociated from it
Right.
as well.
And that transition from, oh my God, and now you're just doing it and you're calm. Right. When I see that in a learner, in a resident, I'm always just like, oh God, like, listen, I want you to be autonomous, but you can't be autonomous if you're this nervous.
Yeah.
Right. Like you've got to find a way to turn it off.
Yeah.
Which is, it's a very, I mean, I was struggling with that all through 5 years of residency because
you were struggling with trying not to look nervous,
trying not to look nervous.
Yeah.
And then that creates an endless echo.
Oh,
like if
if
I turn the camera into the screen, and then you get the endless echo, that's what always happens. People lock themselves in those nerves. And like, as an attending now, I get to watch the resident do it. And now it gets even weirder, talk about the reverberating echoes. I get to think back to my time at Baylor and think about all those attendings who saw me, bundle of nerves, getting onto the console and being like, can I do this surgery?
Yeah.
If you're asking that question, no.
That sounds like a key difference between medicine and surgical training right there. It's like, that's the way medicine people see surgery training.
Yeah.
It's like, if you're going to ask, they're going to yell at you.
The number of tears that I've shed at the robot console, because it's this little box. It's almost like a confessional in there, but it's just you and the screen and the little robotic controllers, and then it's connected to another console that the attending is sitting at, and they can just be reaming you out, right? But you keep working. What are you going to stop? Then it's going to get worse, right? Just follow their directions. They're just coaching you live. And so the way that my brain started internalizing it, watching as much football as I have, like, I'm just the quarterback. And he's giving me a play call, and he's telling me that the blitz is coming and the receiver is open. Just open your eyes, throw the ball. There was so many like, cut it, just cut it. What are you doing? And I'm like, oh God. But now that's the voice that plays in the back of my head when I do robotic surgery, which is a whole nother topic to talk about.
It's a thing, right? Like those phrases that you've heard that just don't leave your mind.
And voices, I think is one of the most important things about what is it like to have somebody's voice in your mind? Like, what does it mean about your relationship with that person? What does it mean about your relationship? And I'm thankful for all of them because they're all my teachers. And because of them now, I get to have the fruitful culmination of 8 years of training.
Yeah. And this is a lot of the stuff that, like, we talk about and we get into. And I think it's great for other people to be able to hear it because it's hard to find these honest conversations. You're not going to find them online. You're not going to find them in Reddit. You're not going to find, what people type is very different from what they say. And what they say when they're trying to make a statement is very different from what they feel or the context, that's taking place. Yeah. And you can only fake it so long, right? So the amount of hours that we've recorded, this is us. There's nothing to hide here. This is who we are. This is who we've been. You'll see it in the other episodes if you don't see it now. We also talk about people's lives a little bit beyond medicine, right? We talk about, how do you deal with whether it's having kids or married or free time at home or, and that kind of stuff. And some of this, as you're saying it, I'm thinking like, yeah, there's some overlap here, right? So you were taught, given this like ability to try something and the confidence, or you getting guided while doing things. And then as you're raising kids, it becomes like, okay, yeah, you want them to try things, but you're scared. And then maybe you'll start yelling at them, give them too much instructions, or you're not sure. And a lot of stuff translates. And I'm thinking like, wow, I wonder if you break down medicine and surgery people, because can you really turn that off or make it different at home? I don't know, right? Because your consequences, I feel like, are just different. And I feel like the same thing with my wife in emergency medicine, where you have to make these quick decisions and they're kind of permanent and really important. And, in nephrology, we don't do too much of that, right? So we say things like, well, we'll check the trend of that over the next couple of days and see what we're going to do about it. I mean, the couple of things that are emergency, quick calls are, they're pretty much in a protocol. Like, yeah, it's an emergency. You're making a call here, but you don't really have too many choices. Right? Like if the potassium is this and the EKG, like you're going to do this, right? Like it's not, it's not. There's not that much.
Yeah, but the algorithms, I think that's one of the other interesting things about knowing an algorithm is knowing when the algorithm doesn't matter. Or like, not in an algorithm, I was like, when is it like, oh, okay, that's what you would normally do, but like this situation is different.
Yeah.
Right. And I feel like I don't know what it's like in a dialysis unit. I've never, but you have to have a way of tailoring that depending on how things are going, right?
Yeah. I mean, I get what you're getting at. In a dialysis unit, it's constant tailoring because, yeah, our patients are just, every one of them just reacts to everything differently. Even if you just look at guidelines for dialysis units, they don't even make sense with everything that you've learned before that. Even survival data, if the blood pressure is too low, they don't live as long. Meanwhile, we've been pushing down blood pressure all our lives. Same thing with like anemia. When you look at blood counts, well, if they're too high, then they don't do well. Everything is like reversed. But then each patient just responds so differently that you're constantly out of protocol for the most part. But I understand what you mean. It's the recognition of like, when is it time to stop following this protocol because something different needs to get done? And sometimes that decision has to happen like this. You don't have time to take out your cell phone and follow whatever chart or something like that. No, you've got to pretty much know that chart so you could divert from it rather than just continuing to do what everybody else, not what everybody else would have done, but what the chart would have done, is hopefully everybody else in your field also knew to divert from the chart.
But then now you're getting into the topic of medical records, which, boy, that's a whole nother talk about first couple of years of attending hood and trying to get used to using. But like at the end of the day, when you break from a quote unquote algorithm, I think one of the things about getting the degree, that's another one of those things about autonomy. Like because people find these algorithms to become, the inverse is also true.
Thank you for joining us for this episode of So You Think You Can Doc. And please like and subscribe to follow us for more great content. Behind every doctor is a journey. Discover the paths, challenges, and choices that shape medicine.